40-year-old man came into your A&E with symptoms of recurrent syncope. Now look at this rhythm strip. Maybe take about 10 seconds or 15 seconds and tell me what you think about it. Background history, bronchial asthma, nothing else. Examine him, he's perfectly fine. Examination, review no abnormalities. You've checked the blood, electrolytes, renal, liver function, all normal. Even an echo is normal. Now, as you can recall from your career, as you progress in the career, our colleagues will look to us as in admiration, because you are the boss. They want to ask, boss, what will you do next? You have got 4 options. Please take a poll, and we are going to explain about this rhythm strip in a while. First option, do angiogram stat, because you see something really dangerous here. Second option, run a 24-hour Holter. Third option, give IV Amiodarone at the A&E. And fourth option, if you want to make me and Dr. Cole happy, ablation. Please poll. Azim, can we take out the poll? All right.
Okay.
And then we'll see how many responses.
There's no option for none of the above this time, which is my favorite. Yeah. Will I be able to see the results? I think I'll be able to see the result later.
So below the interface, there's a polling. There's a polling.
Yeah,
okay,
I can
good.
see it now. I need to scroll a bit.
All right. Good.
Okay, about 46 to around 46 to 48%. Half of them want to give IV Amiodarone. Now,
24 hours is catching up.
yeah, really? Oh, okay. 24 hours Holter. Okay, I'm happy to see that actually not many people want to do Coros, because Coros really, although is a important part of the investigation for a lot of cardiac illness, but in this case, really is not even in the important list. Now, a lot of people say either Holter or IV Amiodarone. Now, I'm going to review the answer for this strip because we need to move on. Now, whatever you do, guys, avoid Amiodarone in this case. 24 hours Holter is fine if you admit the patient in the ward. Even though you want to list the patient as got a semi-E Coros, you're not wrong. But please avoid Amiodarone. Why? Look at the QT interval. Now, I've calculated the QT interval for this patient is at 550 milliseconds. At this juncture, you may want to say that, well, Ma, I have a lot of patients to see. You know, in my practice, I see 50 patients a day in the A&E. Well, I got time to calculate QT interval. Well, you can eyeball it. Now, how to eyeball it? You just look at the onset of QRS complex to the end of T wave. You eyeball that and you compare that to the RR interval. If it's more than half of the R interval, is prolonged. As you can see from this strip, it is staggeringly prolonged. So by giving patient IV Amiodarone, you are prolonging the QT interval even further. So this patient has long QT syndrome. IV Amiodarone should not be a treatment for this patient. Now, why am I saying that in this time of during the virus outbreak is because of this. Now, there's a long list of QT prolonging drugs that you can find on the internet, qtdrugs.org. You can go into it, you can find. It's so long a list that I will not be able to list it on this slide. But these 2 drugs, as you can see from the screen, hydroxychloroquine plus azithromycin has gotten into the spotlight recently. Why? Because of COVID-19. Now, I'm not an infectious disease specialist. I'm not going to comment on the indication to use these 2 drugs, but this is the background, the preamble. During this virus outbreak, I've received numerous text messages, WhatsApp group prompts, and so on and so forth, asking me as an electrophysiologist, what is your EP perspective on this? Now, my answer is quite straightforward and harsh. Jokingly, I say, there is no EP perspective, but there is general medical and cardiology perspective, because there's simply no new perspective or knowledge in this regard. Why? The combination of these two drugs, hydroxychloroquine plus a macrolides, azithromycin in this case, these are two drugs that are well known for years to cause prolongation in QT interval. There's nothing new. So you may have heard of some news saying that combination of these two drugs cause increase in the cardiac risk in arrhythmia, which is true, but it's not something new. So what to take home implication for everyday practice, guys? Follow local international clinical guidelines on the usage of these two drugs. If guidelines say use, please go ahead and use it. But if you must use this combination, please be mindful of the QT interval. What can you do? Do a baseline ECG, calculate the baseline QT interval, and look out the patient co-medication. Look out for any other QT prolonging drugs. For example, amiodarone and sotalol in cardiology field, which is so rampantly prescribed, especially amiodarone. And I used to say that take away amiodarone if you think the QT is already long. I don't see any life-saving, acute, essential indication for amiodarone to be prescribed lifelong for any patient. I used to be saying that in all the conferences internationally and nationally. And last but not least, of course, you must optimize the patient's serum electrolytes, but because that affects the QT interval also. Which makes us to move to the next segment, guys.